Imagine this scenario. You're in the clinic. It's a Tuesday afternoon, and you have a new patient on the schedule. He's a 60-year-old male.
Okay.
He walks in, and he tells you he hasn't been feeling great lately, but he can't really put his finger on it. He's tired, maybe a little loss of appetite, but he insists, Doc, I'm not in any pain. He feels okay. But then you look at him under the exam room lights, and it is absolutely undeniable. He is yellow.
The kind of yellow you can't unsee. It's not subtle.
Not at all. We are talking significant, deep, almost sunflower yellow jaundice. The sclera of his eyes, his skin, it's the whole picture. But here is the kicker. The thing that makes this case so deceptive.
Okay.
He is not writhing in agony. There's no colicky pain like you'd expect with, say, a gallstone attack. He's just yellow, and he's losing weight.
Right.
So you put your hand on his abdomen to examine him, deep in that right upper quadrant, and you feel something.
What do you feel?
It's a palpable, smooth, round mass. It's his gallbladder.
This is the moment where the room usually goes quiet in a medical exam. Or at least inside the doctor's head, it goes very, very quiet.
Because the question on the table, and let's be honest, the question on the exam paper is this just a case of gallstones that have gone rogue? Or is this something much, much more sinister?
If you are a medical student, a resident, or, just someone who loves these high-stakes medical mysteries, your alarm bell should be deafening right now.
They should be screaming.
Absolutely. This specific presentation, the 60-year-old male with painless jaundice and a palpable gallbladder, is arguably one of the most, if not the most, tested scenarios in medical education.
Really? Across the board?
Across the board. It appears in the USMLE, the NEET-PG, the MRCS exams, and the reason it shows up so often isn't just because it's common, it's because it is a trap.
A trap.
It is a massive cognitive trap for the unwary clinician. Your brain, your intuition, it wants to say gallbladder problem because you can feel the gallbladder. You think, oh, it's a stone. But the physiology, the underlying science, it tells a completely different and far, far deadlier story.
Well, today, we are going to walk right into that trap. We're going to dismantle it piece by piece and understand exactly what is happening. We're doing a deep dive into pancreatic carcinoma. Specifically, we're focusing on carcinoma, the head of the pancreas.
This is a heavy topic. I mean, there's no way around it. It's one of the most lethal malignancies we deal with in general surgery.
Right.
But our mission today is to unpack it systematically. We are going to look at the clues, which is the clinical presentation and why it presents the way it does. Then we'll look at the investigation, which is how we use some pretty advanced imaging physics to see the invisible.
And
finally, we're going to talk about the intervention, specifically the high-stakes surgical management known as the Whipple procedure.
And I think it's important to note where our information is coming from today. We aren't just reading from a dense pathology textbook. We are pulling from high-yield medical exam preparation materials.
Which is actually great for this kind of discussion.
Why is that?
Because exam materials, they don't waste time. They focus on two things. Pearls, which are those golden nuggets of high-yield truth you have to know, and traps, which are the common mistakes that everyone makes.
The things they're trying to catch you on.
Exactly.
Right.
So we are going to focus heavily on critical decision-making. What's the next step? What do you not do?
I love that approach. It's like we are hacking the medical board exams to understand this disease from the inside out. So let's go back to our patient. 60 years old, painless jaundice. Where do we even start?
We have to start with the anatomy. I know it's basic, but location is everything in real estate. And it is absolutely everything in pancreatic cancer.
Okay.
When we talk about pancreatic cancer, the vast majority, we're talking about 60 to 70% of cases, are what we call adenocarcinomas. And they are located in the head of the pancreas.
The head. Let's visualize this for a second. That's the part that's sort of tucked right into the curve of the duodenum, correct?
Precisely. Picture the duodenum. That's the very first part of your small intestine. It's shaped like the letter C. The head of the pancreas nestles right into that C loop. It's a very tight, very crowded anatomical space.
Right.
And that location, that specific spot, is the exact reason why our patient is yellow.
It's all about the plumbing.
It's all about the plumbing. You have the common bile duct, which, it's the tube that carries bile from your liver down to the intestine to help digest fats. This duct doesn't just run near the pancreas. It often runs directly through the substance of the pancreatic head. or it's grooved deeply right behind it.
So they're basically fused together.
They're intimate neighbors. So if a tumor starts to grow in the head of the pancreas, what do you think happens to that soft little tube?
It squeezes the tube, it gets compressed.
It acts like a clamp on a garden hose. It physically obstructs the flow of bile. We call that extrinsic compression. And here's the key distinction for the painless part. Unlike a gallstone, which is essentially a rock rolling down a tube, causing these violent spasms and acute colicky pain, a tumor grows slowly.
So it's a gradual squeeze, not a sudden blockage.
It's a slow, progressive, relentless strangulation of the duct. And because it happens slowly over weeks or months, the duct doesn't spasm. It just dilates, it swells up, the bile backs up into the liver, then it spills into the blood, and the patient turns yellow.
But because there is no spasm, there is no pain.
No pain, it's silent.
Wow. That explains the painless jaundice perfectly. It's almost more terrifying because it's so quiet.
It is.
What about the other symptoms? Our source material mentions a sort of triad that goes along with this.
Right, so you've got the yellow skin and sclera, but then you have to look at the patient's output.
Yeah.
The patient will often describe very dark urine.
Like Coca-Cola colored? Is that what we're talking about?
Exactly that color. That's the conjugated bilirubin. Since it can't get into the gut where it belongs, it backs up into the blood, and your kidneys are forced to filter it out. It turns the urine dark brown.
Okay, so that's number 2. What's number 3?
Conversely, because the bile isn't getting into the gut, the stool loses its color.
Ah, because bile is what makes poop brown.
Exactly. Without it, the stool becomes pale or gray or clay-colored. We call that a colic stool.
So dark urine, pale stool. And the third part of the triad.
Pruritus. Intense itching.
And that's not just like dry skin from being sick.
Oh, no. This is a deep, maddening systemic itching. It's caused by bile salts that are supposed to be in your gut, but are now circulating in your blood and depositing in your skin.
That sounds awful.
Patients will often scratch themselves raw. They can't sleep. So if you have a yellow, itchy patient with dark urine and pale stools, that is the absolute classic picture of obstructive jaundice.
But let's get to the aha moment you mentioned earlier, the part that really separates the possibilities. The palpable gallbladder. I think the sources called this the Courvoisier sign.
Yes, this is distinctively high yield. In fact, if you remember nothing else from the clinical exam section of this deep dive, remember Courvoisier's law.
Okay, what's the law?
The definition is very specific. A palpable, non-tender gallbladder in the presence of obstructive jaundice.
All right, let's unpack this because this is where my brain gets stuck. Why is this a sign of cancer and not gallstones? Intuitively, if I have gallstones blocking my duct, shouldn't my gallbladder be full of stones and, big?
That is the logical trap. And that is exactly why this is tested so often.
Okay, explain it to me.
Here's the physiology. If a patient has symptomatic gallstones causing an obstruction, they usually haven't just developed them today. They've had stones for years. This is a chronic condition. We call it chronic cholecystitis.
So the gallbladder has been inflamed over and over and over again.
Exactly. And what happens to tissue that gets repeatedly inflamed and then heals?
It scars.
It scars. Over years of this cycle of inflammation and healing, the gallbladder wall changes. It becomes scarred. It becomes fibrotic. It turns from a stretchy balloon into a tough, leathery, shrunken sac.
So it loses its compliance. It can't stretch anymore.
Exactly. It cannot distend. So even if a stone gets stuck and pressure builds up, the gallbladder stays small and shrunken because the scar tissue literally won't let it expand. You can't feel a shrunken gallbladder on exam.
I see. Okay. But with cancer?
With pancreatic cancer, the blockage is distal. It's way down in the pancreas head. But crucially, the gallbladder itself is usually healthy. It hasn't been scarred down by years of inflammation because the problem isn't in the gallbladder, it's the pancreas. So the gallbladder wall is still thin and soft and elastic.
So when that tumor slowly clamps off the bile duct from below,
the bile backs up, the pressure builds, and because the gallbladder is healthy and elastic, it just inflates like a water balloon. It gets huge.
Yeah.
Huge enough to feel through the abdominal wall as a smooth, round, non-tender mass.
That is fascinating. It's a physics problem, really. A big, soft, painless gallbladder points to a downstream tumor. A shrunken, probably painful gallbladder usually points to stones.
Broadly speaking, yes. That is the essence of Courvoisier's sign. It tells you the obstruction is likely neoplastic cancerous, not calculous or stone-based. It's a beautiful clinical sign.
Now, we focus heavily on the head of the pancreas, But you mentioned that's only 60 to 70% of cases. What about the other 30%? The tumors in the body and the tail?
And this, unfortunately, is the tragic side of the coin. Tumors in the body or tail of the pancreas behave very, very differently.
Why?
Simple anatomy again. The bile duct does not run through the tail of the pancreas.
So, no jaundice.
Correct. They do not cause early jaundice. There is no early warning system. There's no yellow flag. These tumors can grow quite large without pressing on the bile duct at all.
So how do they present? What are the symptoms then?
The symptoms are incredibly frustratingly vague. The patient might have some epigastric pain.
So upper stomach pain.
Right. And it often radiates to the back.
Why the back? That seems odd.
Because the pancreas is a retroperitoneal organ. It sits way back in the abdomen, right up against the spine. As the tumor grows, it can start to infiltrate the nerve plexuses that are near the spine. That causes a deep, gnawing back pain.
Okay, so back pain, weight loss. What else?
That's often it. Back pain, weight loss, and fatigue. But think about it. How many conditions cause those symptoms?
I mean, that sounds like getting older, or straining a muscle at the gym, or stress.
Exactly. And that is why body and tail tumors have a significantly poorer prognosis. By the time they are finally found, they're usually huge, or they have already metastasized. They are the true silent killers.
So the head tumors at least have the courtesy, if you can even call it that, of turning the patient yellow while the tumor is potentially still small and treatable.
It is the only early warning sign we have for this disease. The jaundice is, paradoxically, a lucky break if it catches the disease early enough.
That is a very sobering thought. Okay, let's move on to the suspect profile. Who gets this? I feel like every time we discuss a major cancer, we end up talking about the same usual suspects.
And the usual suspects are definitely here. When we look at the rap sheet of risk factors for pancreatic carcinoma, one stands head and shoulders above the rest.
Let me guess. Smoking?
Smoking. It is identified as the strongest modifiable risk factor.
Modifiable meaning you can do something about.
You can stop. If you stop smoking, you reduce your risk. It's that simple. The carcinogens in tobacco smoke are absorbed into the blood, and then they're actively secreted into the bile and the pancreatic juice. They literally bathe the ductal cells in poison day after day.
What about alcohol? I feel like the pancreas and alcohol are always linked in my mind.
That's a great point, and it's a bit nuanced. Alcohol is a major, major cause of chronic pancreatitis, and chronic pancreatitis is a definite risk factor for cancer.
So an indirect link.
It's a strong indirect link. But interestingly, smoking is a more direct and potent driver for the adenocarcinoma itself, independent of pancreatitis.
Okay, what about things you can't change? Genetics. The sources mention the BRCA mutation. I usually associate that with breast or ovarian cancer.
It's becoming increasingly relevant in pancreatic cancer, too. We're learning that BRCA mutations, particularly BRCA2, along with conditions like hereditary pancreatitis, significantly elevate a person's lifetime risk.
And does that change anything?
It can. This is important because it changes how we might treat them. There are specific drugs, PRP inhibitors, that can target BRCA-mutated cancers, so knowing the genetics matters. But there is one specific red flag or exam pearl from the source material I really want to highlight. It's so important. It involves diabetes.
I saw this in the notes. New-onset diabetes.
Yes. This is absolutely crucial for anyone in primary care. If you have an elderly patient, let's say 70 or 75 years old, who suddenly develops diabetes out of the blue, that is weird.
Why is it weird? I mean, doesn't diabetes happen to older people?
Well, type 2 diabetes is usually a disease of middle age. It's associated with metabolic syndrome, obesity, insulin resistance. It develops over years. It doesn't usually just pop up out of nowhere in a relatively thin 75-year-old who's had normal blood sugar their whole life.
So if a thin, otherwise healthy senior citizen suddenly has high blood sugar,
do not just write a prescription for metformin and send them home. That is a massive red flag.
what's the connection?
We think the cancer itself can secrete factors that induce a diabetic state, or it might just be physically destroying the insulin-producing islet cells in the pancreas.
So the tumor is causing the diabetes.
It can be the very first sign. New-onset diabetes in an elderly patient demands an investigation for pancreatic cancer. It shouldn't be dismissed as just a routine part of aging.
That is a huge takeaway. It's not just, oh, you're getting older, your sugar is up. It's a potential alarm bell for a hidden tumor.
Precisely. It's often the very first sign, sometimes preceding weight loss or jaundice by month.
Okay, so we have our patient. We suspect the worst. Now we need to prove it. We're moving into Section 3. The investigation, the detective work. Our patient is yellow. what is the absolute first thing we do?
The first step, almost always, is an ultrasound.
Okay, why ultrasound? It isn't CT the gold standard.
Yeah. CT is better for detail, for staging, but ultrasound is the perfect first-line screening tool for jaundice. Think about it. It's non-invasive, there's no radiation, it's cheap, and it's accessible.
And what question is it trying to answer?
It's excellent at answering one specific question. Are the bile ducts dilated? Yes or no?
Because if they aren't dilated,
then the jaundice is probably medical. It could be hepatitis, maybe a drug reaction, something wrong with the liver cells themselves. But if the ducts are dilated, we know there is a physical plumbing blockage somewhere. Ultrasound is fantastic at seeing fluid-filled tubes.
but can the ultrasound actually see the tumor itself? The thing causing the blockage?
Often no, and that's the big limitation. The pancreas is deep in the abdomen, it's tucked behind the stomach and intestines, bowel gas scatters ultrasound waves like crazy, so the pancreas, especially the head, is often completely obscured.
So ultrasound confirms the blockage, but it might not show us the blocker.
That's a perfect way to put it. Once ultrasound confirms, yes, the ducts are dilated, this is obstructive jaundice, then we bring out the heavy artillery, the CT scan.
But not just any CT scan, right? The sources were very, very specific about this.
Correct. You can't just order a routine abdomen pelvis CT. You need a triple-phase contrast CT or a pancreatic protocol CT.
What does that mean, triple phase? Why can't we just take one picture? Why three?
This comes down to hemodynamics. It's all about how blood flows through the organ and the tumor. We inject the iodine contrast dye, and then we take images at 3 very specific times.
Okay, walk us through the phases.
So first is the arterial phase. We take a picture very quickly, about 20-25 seconds after injection, when the dye is lighting up the arteries. Now, pancreatic adenocarcinoma is what we call a hypovascular tumor.
Meaning it doesn't have a lot of blood vessels.
Exactly. It creates a lot of scar tissue.
Yeah.
We call it a desmoplastic reaction, and it doesn't have a rich blood supply. The normal pancreas, on the other hand, is very vascular.
So on the scan,
The normal pancreas lights up bright white with the dye. The tumor, being hypovascular, stays dark gray. So you see this dark spot against a bright background that helps us define the tumor's edges.
that's clever. Okay, what's the next phase?
The portal venous phase. We wait a bit longer, maybe 60-70 seconds, until the dye has flowed out of the arteries and into the veins, especially the portal vein. This is the most crucial phase for staging,
Why saging?
because this is when we can see if the tumor has grown into or is touching the major veins, like the portal vein or the superior mesenteric vein. That information is critical for determining resectability, which we'll get to.
So the timing of the scan is everything.
If you get the timing wrong, you might completely miss a small tumor, or worse, you might misjudge its relationship to the blood vessels and make the wrong decision about surgery. That's why you can't just order a routine scan. It has to be a specific pancreatic protocol.
And when we are looking at these images, these perfectly timed pictures, there is a specific sign we are hunting for, the double duct sign. It sounds like a secret handshake or something.
It's a classic exam phrase for sure. The double duct sign refers to the simultaneous dilation of 2 ducts, the common bile duct, or CBD, and the pancreatic duct.
So both pipes, the bile pipe and the pancreas enzyme pipe, are backed up.
Exactly. And anatomically, where do those 2 pipes meet? They join together right at the ampulla of Viter, which is located smack in the head of the pancreas. So if both are dilated, it implies the blockage is happening at their junction or just before it.
Like a traffic jam on 2 merging highways, caused by a big crash right at the on-ramp.
That is a perfect analogy. If you see the double duct sign on a CP scan, you are almost certainly dealing with a periampullary or pancreatic head tumor that's compressing both exits.
Now, what about blood work? I see CA 19-9 mentioned everywhere in the literature. Is that our smoking gun? Can we just do a blood test?
And CA 19-9. This is the classic MCQ trap, the multiple choice question trap.
Lay it on me. Why is it a trap?
Because students, and honestly, sometimes doctors who should know better, want it to be a screening tool. They want to say, let's just test everyone over 50 for CA 19-9 to find cancer early. But you absolutely cannot do that.
Why not?
2 big reasons. First, sensitivity. About 10% of the population is what we call Lewis antigen negative, meaning they genetically cannot produce the CA 19-9 protein. So they could have a massive tumor, stage 4 disease, and their CA 19-9 marker would be 0. You'd falsely reassure them and miss the cancer entirely.
Wow. Okay, that's a huge blind spot. And the second reason?
Specificity. or lack thereof. CA-19-9 can be elevated in many benign conditions. If you have cholangitis, that's an infection of the bile duct, or even just heavy jaundice from any cause, the irritated bile duct cells can produce tons of CA-19-9. It can skyrocket into the thousands, mimicking cancer perfectly.
So a high number doesn't automatically mean cancer.
Not at all. A low number doesn't rule it out, and a high number doesn't rule it in.
So if it's not for diagnosis, why do we even use it? What's its purpose?
Its true utility is for monitoring a known cancer. Let's say we diagnose you with cancer via CT scan, and your baseline CA-19-9 is 1,000. We operate. We perform a successful Whipple procedure.
The number should drop.
It should drop to 0 or close to it, and then we watch it. If 6 months later it creeps back up to 200, we know the cancer is back, often before we can even see it on a scan.
So it's a tracking device, not a metal detector.
That's the perfect way to think about it. Use it to track the enemy, not to find him in the first place.
Okay, so we have the diagnosis. We see the mass on the CT. Now comes the biggest, most critical question of all. Can we operate? This leads us to Section 4, the decision matrix.
This is the absolute heartbeat of pancreatic surgery. The entire conversation revolves around the concept of resectability.
And I assume resectable just means can we cut it out?
Yes, but the criteria are extremely strict because pancreatic surgery is so unforgiving. Resectability isn't just about how big the tumor is. You could have a huge 8-centimeter tumor that is resectable and a tiny 1-centimeter tumor that is completely unresectable.
How is that even possible?
It is all about vascular involvement. It's about the tumor's relationship with its neighbors. The pancreas is located in a very dangerous neighborhood. It is right next to, and sometimes wrapped around, the most important blood vessels in your abdomen. The superior mesenteric artery, SMA, the superior mesenteric vein, SMV, the portal vein, and the celiac axis.
High-value real estate?
The highest. The SMA, for instance, provides the blood supply to your entire small intestine and part of your large intestine. You cannot live without it, period.
So what specifically makes a tumor unresectable? What's the line in the sand?
The hard line is arterial encasement. If the tumor has wrapped itself around the major arteries, specifically if it encases the superior mesenteric artery or the celiac axis by more than 180 degrees.
180 degrees, so it's like a cuff hugging more than half the vessel.
Exactly. If it encases the artery like that, it typically means it has invaded the vessel wall itself. You can't just peel it off. To remove the tumor, you would have to remove that segment of the artery, and as we said, that's generally not compatible with life. So significant arterial encasement makes it unresectable.
What about distant spread?
Oh, absolutely. If there is distant metastasis, if it has spread to the liver, the lungs, the peritoneum, it is automatically unresectable. Stage 4 disease. Surgery won't cure a systemic disease.
What if it's just touching the artery? Or what if it's involving a vein?
Now you're getting into the gray area. If it is touching an artery less than 180 degrees, or if it's only involving the vein, the SMV or portal vein, we often call it borderline resectable.
Borderline, that sounds like a surgeon's nightmare. A gray area.
It is. In these cases, we often don't go straight to the operating room. We use what's called neoadjuvant therapy.
So chemo before surgery.
Exactly. We give chemotherapy, sometimes with radiation, before we even think about operating.
And what's the goal there? What are you trying to achieve?
We are trying to shrink the tumor away from those blood vessels. We're trying to buy ourselves a margin. Even a single millimeter of shrinkage, pulling the tumor off the vein, can turn an unresectable or borderline resectable tumor into a clearly resectable one.
So surgeons are literally sitting in a dark room, looking at these CT scans, and measuring millimeters of clearance between the edge of the tumor and the wall of an artery.
Millimeters matter. It is the difference between a chance at a cure and a referral to palliative care. The stakes could not be higher.
Let's say we get the green light. The neoadjuvant chemo worked, or the tumor was clearly resectable from the start. We are going to the operating room. We are about to perform one of the most famous and most complex surgeries in the book, the Whipple procedure.
The Whipple, or to give it its formal, very long title, the pancreaticoduodenectomy. It is a procedure of immense surgical depth and history. It's often considered the Mount Everest of general surgery.
Just the name sounds intimidating. Pancreaticoduodenectomy. Breaking that down.
It basically describes what we remove. And for the exams, you absolutely need to know exactly what comes out. It's a standard select all that apply kind of question.
Okay, let's list the inventory. What are we taking out of the patient during a Whipple?
We are removing the head of the pancreas, obviously, because that's where the tumor is. But you can't just take the head by itself.
Why not?
Because the head of the pancreas shares its blood supply with the duodenum.
They share the same arteries.
Yes, the superior and inferior pancreaticoduodenal arteries. They form an arcade.
Yeah.
You can't safely separate them without causing one or the other to die from lack of blood flow. So if the head goes, the duodenum, the entire C-loop of the small intestine, has to go with it.
Wow. Okay, so pancreas, head, and duodenum. What else is on the list?
We remove the distal or lower part of the common bile duct. We remove the gallbladder, which is attached to it. And in the classic version of the surgery, we also remove the distal part of the stomach, specifically the antrum.
That is a lot of organs. You are basically hollowing out the upper central abdomen.
You are dismantling the central junction of the entire digestive tract. You are taking out the mixing bowl, where food from the stomach, bile from the liver, and enzymes from the pancreas are all supposed to meet.
But you can't just leave it like that. The patient still has to eat. You have to reconnect the plumbing.
Correct. The resection is only half the battle. The reconstruction is arguably the hardest part. You now have 3 open tubes that need to be reconnected to the intestine so the patient can digest food again. We call these connections anastomoses.
Okay, walk us through the plumbing. This seems incredibly complex.
It is. Imagine you have a loop of jejunum, that's the next part of the small intestine, and you bring it up into the upper abdomen. First, you have to sew the stump of the remaining pancreas into the side of this loop. This is the pancreaticoduodenectomy.
Is that a difficult connection to make?
It is the most feared part of the entire operation. The pancreas is not like muscle or stomach wall. It's soft, it's glandular, it's friable. Surgeons often describe it as trying to sew tofu or wet blotting paper. The stitches just pull through.
That sounds like a nightmare.
And remember what the pancreas does. It makes powerful enzymes designed to digest meat. If this connection leaks, that fluid gets out into the abdomen and starts digesting the patient's own tissues, their own blood vessels. A pancreatic leak is a catastrophic, often fatal complication.
Yikes. Okay, that's 1 connection down, 2 to go.
Second, slightly downstream on that same loop of intestine, you have the open bile duct coming from the liver. You have to sew that into the intestine so bile can flow. That's the hepaticoduodenectomy. This is usually a bit sturdier, but easier to sew.
Okay, and the third and final connection.
The stomach. You have to reconnect the stomach to the intestine so food can pass through. That's the gastroduodenostomy.
So 3 critical connections: pancreas, liver, stomach, all plumbed back into the small intestine in a very specific order.
Exactly. It's a tour de force of visceral surgery. It can take 4 to 6 hours, sometimes much longer, and the margin for error is essentially 0.
And just briefly, what if the tumor isn't in the head? What if it's in that silent 30% the body or tail? Is it the same operation?
No, then the surgery is completely different. We perform a distal pancreatectomy. We are essentially removing the left side of the pancreas.
Do we have to take the duodenum or stomach then?
No, luckily the tail of the pancreas has a separate blood supply. But the tail of the pancreas is intimately connected to another organ, the spleen. The splenic artery and vein run right along the top of the pancreas on their way to the spleen.
So the spleen is collateral damage.
Usually, yes. To get a clean oncologic margin, you can't just dissect those vessels off the tumor, so we have to take the spleen as well. A distal pancreatectomy and splenectomy.
Is that surgery easier than a Whipple?
Technically, yes, it's a simpler operation. There's no major reconstruction needed. You just staple or sew off the pancreas stump. But here's the paradox. Remember, the prognosis for these tumors is often worse because they're found so late. So even if the surgery is easier for the surgeon, the outcome is often poorer for the patient.
Which brings us to the really hard truths of this deep dive. Section 6. When surgery fails, what happens if the patient is unresectable? What if that CT scan shows the tumor is wrapped around the SMA artery?
Then we have to shift gears completely. We move from curative intent to palliative intent. We have to accept that we cannot remove the cancer, so our goal becomes maximizing quality of life and extending it as much as possible.
And how do we manage that? What are the priorities?
The biggest, most immediate issue is usually the jaundice and the itching. It's absolutely miserable. So even if we can't do a Whipple, we can still relieve the blockage. We do an ERCP.
That's the endoscopy.
Right. We use an endoscope to go down the throat, into the duodenum, find the blocked bile duct opening, and slide a stent, a small plastic or metal tube, right through the tumor.
Like putting a pipe through a landslide to open the road.
Exactly. It's a tunnel through the mountain. It pushes past the tumor and lets the bile drain. The jaundice clears, the itching stops. The patient feels much, much better, often within a day or 2.
What about the pain? You mentioned that gnawing back pain.
Pain management is absolutely critical. These tumors can invade that nerve plexus behind the pancreas, the celiac plexus, causing intense, unrelenting back pain. We can perform something called a celiac plexus block. Anesthesiologists or interventional radiologists can inject alcohol or anesthetics directly into those nerves to kill them and block the pain signal.
And what about treating the cancer itself? Are there drugs?
Yes, chemotherapy. The standard of care right now for patients who are strong enough is a regimen called FOLFIRINOX. It's a cocktail of 4 strong chemotherapy drugs. It can extend survival by several months and improve quality of life, but it's an aggressive treatment with significant side effects.
And there's a specific exam trap mentioned in the sources here regarding surgery in metastatic cases.
Yes, and the rule is hard and fast. If there is metastatic disease, if the cancer has spread to the liver or lungs, you generally do not do a Whipple.
Never.
Almost never. The surgery is too huge, the recovery is too long, and it offers no survival benefit if the cancer is already systemic. It's a systemic disease that needs systemic treatment, which is chemotherapy.
Let's talk numbers. I know they aren't good, but we need to state them. What is the prognosis for pancreatic cancer?
It is one of the grimmest in all of medicine. The overall 5-year survival rate for all stages combined is hovering around 10 to 12%.
That is incredibly low.
It is. And the reason isn't that we're bad at the surgery. The reason is that most patients, probably 80% present late, by the time they turn yellow, or certainly by the time they have that vague back pain, the horse has often left the barn. The biology of this tumor is just incredibly aggressive.
Before we wrap up the case, we should touch on the differential diagnosis. What else could this be? If we see a mass in the head of the pancreas on a CT, is it always pancreatic adenocarcinoma?
It's important to keep an open mind, even though it usually is. It could be a focal mass of chronic pancreatitis, though that usually hurts and looks different on imaging. It could be a cholangiocarcinoma, which is cancer of the bile duct itself happening to grow in that location.
Okay.
Or, and this is a really important distinction, it could be an ampullary carcinoma.
So that's a cancer of the ampulla, the little nipple where the duct actually enters the intestine.
Yes. And interestingly, ampullary carcinoma has a significantly better prognosis than pancreatic cancer.
Why is that? Is the tumor just less aggressive?
It's partly biology, but it's mostly location.
Oh.
Because the ampulla is literally the exit door, even a tiny tumor there. The size of a pea blocks the flow almost immediately.
So they turn yellow instantly when the tumor is tiny.
Yes. They present with jaundice when the tumor is just 1 or 2 centimeters. Pancreatic cancer might not cause jaundice until it's 3 or 4 centimeters and has had more time to spread. Because ampullary cancer is caught so much earlier, the resectability rate is higher and the 5-year survival is much better, maybe 40–50%.
So distinguishing the exact origin really matters for the patient's future.
It matters tremendously.
Okay, let's circle all the way back to our 60-year-old patient from the intro. We have taken him through the ringer.
We have.
So 60-year-old male, progressive, painless jaundice, a palpable, non-tender gallbladder. What's the verdict?
The verdict is, until proven otherwise, carcinoma of the head of the pancreas.
And the next step. What is the single most important next step?
Do not go straight to an ERCP to put a stent in. That's invasive, and it can inflame the area and make a future surgery harder. The correct next step is a high-quality imaging study for staging. A contrast CT abdomen, specifically a triple-phase pancreatic protocol.
And as you said, structured thinking prevents delay.
Absolutely. Don't guess. Image, stage, then plan.
Fantastic. Let's hit the rapid-fire pearls. The key takeaways for everyone listening to lock this into their brains. I'll tee them up, you knock them down.
Let's do it.
Most common type of pancreatic cancer.
Adenocarcinoma.
Most common site.
The head of the pancreas.
Painless jaundice plus a palpable gallbladder equals malignancy. What's the name of that sign?
Courvoisier sign.
The imaging finding of a simultaneous dilation of the common bile duct and the pancreatic duct.
The double duct sign.
And the single strongest modifiable risk factor.
Smoking. By a mile.
And finally, the blood test. CA 19-9. Is it diagnostic?
No. It is for monitoring only. Do not fall for the trap.
Fantastic. Now, usually we end here, but I know you have one final provocative thought to leave us with. Something for us to chew on.
I do. I want to leave you with a reflection on that differential diagnosis we just touched on. The ampullary cancer versus the pancreatic cancer. Clinically, in the beginning, we lump these patients together because they look the same. They're yellow and they're painless. But their futures, their prognosis, are vastly different. And I think the challenge for the next generation of medicine isn't just finding the mass on a CT scan, it's defining the biology of that mass. Why does one 2-centimeter tumor kill a patient in 6 months and another is curable with surgery?
Right.
The future has to be molecular. It's about knowing the genetic fingerprint of that specific tumor, not just its location. Precision in diagnosis, understanding the why of its aggression, is the only way we are going to improve those daunting survival odds.
That is a powerful place to stop. Precision medicine is the next frontier. Thank you so much for taking us on this incredibly detailed deep dive.
My pleasure.
For our listeners, remember, Painless Jaundice is a siren song you absolutely cannot ignore. Follow the clues, trust the structure, and you'll ace the case. Until next time.